If you've ever wondered how a physical therapist helps to treat people with low back pain, then this video is for you. Welcome everyone to the video. This video will be part of a long series that I will be doing on low back pain evaluation and treatment. My name is Nick Helton, aka Dr.Nick.DPT, and today I want to walk you through how I would typically evaluate a patient that comes in with low back pain. In this entire series, I'm going to walk you through the entire evaluation process from start to finish so you know what to expect when you're going in to get your back evaluated. Before I begin, do me a quick favor and smash that like button and subscribe for the YouTube algorithm. One of the most common narratives that I hear from people is that they didn't know that physical therapists treat the spine. Some people are genuinely surprised by that. But the truth is that physical therapists see a wide range of musculoskeletal conditions, including, of course, the spine. The estimates are that up to 80% of the US population will experience low back pain or lower extremity pain at least once in their lifetime. These conditions are common reasons for physician visits. Acute low back pain is usually a self-limiting condition. Most patients will experience symptomatic resolution irrespective of their treatment. Although current guidelines recommend non-pharmacological and conservative measures, the costs of care associated with low back pain and lower extremity driven pain remain significant. In 2013 alone, spinal conditions defined as both neck and back pain accounted for the third largest portion of total national health spending after diabetes and ischemic heart disease. Now I know that sounded like a complicated series of sentences that maybe didn't make a lot of sense out of context, but what I wanted to try and convey is that low back pain is an extremely common thing. It affects the majority of us throughout our lifetimes. Most symptoms will typically resolve on their own. However, there is a subset of people who continue to have persistent problems, chronic pain, however you'd like to frame it, but that subset of the population continues to struggle with low back pain. And as it's such a common and costly issue, I wanted to make a video that discusses some of the false narratives surrounding low back pain, as well as provide some more information for those who are currently dealing with it. I'm going to try to be as thorough as I can here, but full disclaimer, not every single evaluation is the same. Humans vary and unique circumstances happen. There is no possible way for me to cover every single aspect of every single evaluation. I'm just trying to capture the general principles that I believe should be in every single effective evaluation. That said, let's define what a physical therapy evaluation is. So, a physical therapy evaluation is the term used for the entire process of the first visit of seeing a physical therapist. In simplistic terms, the evaluation can be divided up into the subjective or the history discussion, the objective or the clinical tests and measures, the assessment or your professional opinion on the subjective and objective data that you have gathered, and the plan, or essentially your overall, for lack of a better term, plan of what you tend to do in the future for that given individual to help them reach their goals and address the things that you found within the evaluation. Basically, the subjective portion should give you several hypotheses to be able to test, or to put it even more simply, listen, test, retest, assess, and plan. That's basically it in a nutshell. In this video today, I will be going over the subjective portion of the evaluation, which in my opinion is the most important portion of the entire evaluation. Future videos will go over the other sections that I previously had discussed. The initial phase typically starts with some intake paperwork that is done prior to the session. Honestly, no one enjoys filling out paperwork, and I totally understand that. However, the intake paperwork contains everything from pain to medications and surgeries. And when I look at the intake paperwork, I'm looking for what are called red flags. Now, red flags are things that make me suspect something a bit more sinister. They may be immediately obvious, something like cauda equina syndrome, which is essentially a life-threatening spinal cord compression, or they might not be obvious at all and require further testing, further questioning, as well as further investigation to determine whether or not this specific thing would be considered a red flag. Now that said, red flag conditions are exceedingly rare. The majority of low back pain tends to be non-specific, about 90% of that, as you can see in this infographic here, with estimates of 1 to 2% of serious medical pathology that needs an immediate referral. The remaining percentages are low back pain with neurologic deficits, and a neurologic deficit is essentially a sensory, motor, or functional loss that may be caused by some sort of nerve-related issue. Typically, this can be referred to as things like sciatica or radiculopathy or something along that spectrum. After ruling out red flags with confidence, you can then reassure the patient on the natural history of the disease as well as the regression to the mean over time. Next is looking for yellow flags, which are essentially going to be considered more in the psychosocial realm. All that essentially means is that a yellow flag could be something like depression, fear avoidance beliefs, or maladaptive coping strategies that might be affecting the patient long term and having an impact on your clinical outcome. Typically, I have the patient fill out some kind of disability survey which might capture some of the previously mentioned yellow flags as well as hopefully some of the red flags. These disability surveys can be something as simple as what's known as an Oscillatory back disability scale, which I have on the screen here, which just asks a series of questions on the patient's function. The disability survey is a general tool that can help give us an idea of the patient's function, but it's also a valid tool to assess progress over time compared to when they first came in for the initial evaluation. I then spent some time reviewing the chart thoroughly, looking through any information that I may have missed, and trying to go over some questions in my head and pre-frame some ideas and things that I might want to ask once I start talking to the person and get them back in the evaluation room. Some real key points about the subjective portion of the evaluation that I really want to establish before even going in. One, I really want to establish a rapport with this patient. I really try my best to actively listen to the individual in front of me. I've read that on average a person might get interrupted something like 10 seconds into their actual conversation while they're in some sort of medical office. So I try my best to try to really actively listen to that person and give them the amount of time that they need to discuss the issues with me freely. I also try to define and identify barriers that might be stopping them from preventing or from reaching their goal, and then essentially trying to figure out why that barrier is there and what we can do to remove it. And finally, I try my best to not have the person walk out of the evaluation thinking that they are weak or broken or sort of worse off coming out of the evaluation than they were going into the evaluation. And that doesn't mean I try and be disingenuous and not honest with the person, but I try to focus just as much on their strengths as their weaknesses and highlight those on an equal scale as opposed to really just hammering down only on the negatives, if that makes sense. I personally don't try to be hyper structured during the subjective portion of the evaluation. I find that I tend to do better and really connect with the person when I just let the conversation flow. And that doesn't mean that I don't still have a list of objectives that I need to accomplish and information that I need to gather, but I tend to find that if you allow the person to speak and then try to base your questions off that conversation, you can get a lot better information overall than trying to just jar information randomly and throwing questions at them incessantly. This infographic that I made sort of highlights that idea of what I'm trying to accomplish and information I'm trying to gain from the subjective portion of the evaluation. So OPQRST is the mnemonic that I definitely did not come up with that is useful to help remember some of the main factors to ask more questions about. Now again, none of these are absolutes. They are guidelines that may help move you in the right direction for the specific line of questions. After I've gone through all of the above things that I just mentioned, I try to have a primary, a secondary, and perhaps even a tertiary hypothesis in mind that I'd like to try to get to the bottom of in the objective portion of the evaluation. Sometimes I write it down, sometimes I just keep it in my head, but those three things should sort of direct how you are testing in the objective portion and should sort of lead to your why. So if you are selecting a specific test or specific movement or activity, it should be based on what you found in the subjective portion of your exam. As a general principle, I find it's much more important to rule out red flags than it is to rule in specific conditions like shoulder impingement or rotator cuff atrophy or things of that nature. I'm going to do a whole video on shoulder impingement and pathologies and those sort of things in a future video, so I'm not going to get into it right now, but suffice it to say, again, ruling out red flags much more important than ruling in some diagnoses that may or may not change your course of care or course of clinical action. Also, please remember, this is not by any means all-inclusive. This is general principles for an orthopedic evaluation of the spine. There are a wide variety of diagnoses that get evaluated, anything from your neurologic conditions all the way to pediatrics, to geriatrics, fall risks, stroke victims. There are all kinds of varieties of patients that come in, and there are lots of other tests, ideas, questions that need to occur. This is sort of just a general principles of orthopedic examination of the spine that I tend to find are commonalities in most of my evaluations. And given the numerous varieties, it would be almost impossible to cover them all in one short video. Speaking of short videos, I feel like I have been talking forever, so I'm going to leave it at that. Did you learn something? Did I miss something? Do you have questions? If so, drop them in the comments below and let me know. Again, this is part 1 of the series going over the subjective portion of the evaluation. I'm going to be making future videos on the objective assessment plan and then even some treatment sessions as well. I want to try and get a full kind of spectrum of things to kind of look for when looking at the low back. Thanks for watching. I appreciate you, and please stay tuned for the rest of the low back pain series.